First, I just want to say thank you for the opportunity to speak with you today. Um, I'm on faculty with Belmont University, which is in Nashville, Tennessee. I'm a professor there, and I've been teaching at Belmont since 1998. I also am the director of our motion analysis lab, and I teach in the area of biomechanics and orthopedics. I'm also still a practicing clinician in the clinic 2 half-days a week. And my research is really in the areas of injury prevention, and especially within the lower extremity. That's both in sport as well as the performing arts. What I'd like to talk with you guys a bit today is about a preseason screen that I've been using with a local Division I women's college basketball team. And then really looking at the data from the screen, and specifically the data of the players who were injured, and seeing some of the indicators that we were looking at. Then I have like to talk with you some about some ideas for future data analysis, some areas that we can begin to look into and maybe better identify these folks before the injury happens as well. And then we'll have plenty of time for questions. So anyways, let's go ahead and get started. I know you guys only have a short period, so I want to make this as beneficial as possible for you. So as Aaron was saying, we're going to talk about preseason screens to prevent in-season injuries. And essentially the screen that I was asked to do is this particular basketball team the previous season, they had a really good run. But quite honestly, by the end of the season, when they started making their conference tournament and their push for the NCAA berth, they literally only had 7 kids available to play. We looked at a variety of things with our screen. We assessed strength of the proximal hip muscles, the abductors and the extensors, and I used hand dynamometry there, and I'll talk a little bit more about that shortly. We looked at balance, both eyes open and eyes closed, but it wasn't the traditional single leg stance, because in basketball, the athletes are rarely flat-footed. They tend to be up on the ball of their foot. So we actually place them in slight hip flexion, knee flexion, and have them up into plantar flexion where they're up on the ball of their foot, and then see how they can hold that position, both eyes open, eyes closed, for time. And then we did more of what I consider a traditional movement screen. I used the MyEmotion system for that. We looked at a squat, single leg jumps, and then we had them do a vertical jump. And there I have a force plate in the clinic, so we had them jump and land on the plate. And again, I'll talk with you some shortly about that data and what we were able to ascertain from that. So now that you have sort of an idea of what the screen looked like, now I need to point out that when these players came, all right, first, the screening was done in the middle of September. This was actually what the university requested, that it not fall into the middle of September, because they wanted to make sure their incoming freshmen had gotten there and gotten acclimated to their program. It was done on a Saturday morning, again, working within their scheduling timelines, and the athletes arrived at the clinic. We wanted to begin data collection at 8. They arrived at 7:30. They were allowed to stretch, loosen up, ride a stationary bike, whatever they needed. But I need to point out that they were not fatigued, okay, at all prior to this screen. Then we actually just cycled them through. We had multiple stations. We're looking at, again, height, weight, balance, doing the strength assessment, and then finally the MyEmotion. All right, so this report was compiled for each athlete and then given to the strength and conditioning coaches from there. So what I would like to do is actually spend time looking at the data of the players who sustained injuries during that season. This young lady essentially suffered with left knee pain throughout the season. You can see here from her doing a single leg squat. She does tend to drift a bit toward midline with the knee. There is a little bit of wobble, what I refer to as wobble in the frontal plane of the right knee, but overall it's not terrible form. Then on the left, there we go. You can see a bit more adduction of that hip and that movement within the frontal plane, especially. And if we look at her kinematics, right versus left, you can see that really she goes into considerably more hip adduction, about 19 degrees on the left compared to only about 4.5 on the right. Additionally, when looking at the hand dynamometer data, she also had a 11.6% deficit in strength of her glute medius, with the left being weaker as compared to the right side. So this kind of fit what we were seeing from a strength standpoint as well. She also had diminished balance on that left side, and both eyes open and eyes closed compared to the right. Now, for more of a dynamic task, we looked at single leg jump, and just in case you're not entirely familiar with the MR3 software, let me just take just a minute to kind of show you this page. On your left, this is the actual data that you're seeing in real time for all three planes of the hip, knee, and ankle. I use a video camera with my system. That way I can actually get an image, and then the avatar, which you can move any direction. You can spin it side to side, up, down. It doesn't matter from there. The reason I enjoy the video camera is with the reports that I put together for my athletes and patients, I take screenshots of the individual actually showing them. From an athlete's, dealing with athletes, the numbers really does not really resonate well with them, but if you can actually show them as far as looking at these abnormal positions, that really resonates with them. But nonetheless, and looking at her single leg jumps, and now on the left side, there you go. And I think you could easily see the difference in form, left versus right. Now, the other thing I need to point out is this player is right-handed. So she tends to jump more off her left foot during her sport because of that as well. So again, looking at her kinematics, you can see as far as they did not really adduction of the hip wasn't as significant as we saw as in the single leg stance, but she also did not go through as much hip and knee flexion as well. She landed much stiffer than that. Now, let me move you to another player. So the other one before we spoke about strength deficits, but let me introduce to you this young lady. Unfortunately, she sustained very early in the season, actually the end of October, she sustained a right ACL tear. She's one of their forwards as far as by position. She's 6'3" in height. And let me show you her single leg squat. And now on the right side. Here we go. All right. Now, in looking at her data, you see a great deal of hip adduction actually on both sides, right and left. Minimal hip flexion on the right as compared to the left, as well as knee flexion. Now, when we look at this individual, if she had similar strength deficits as the athlete that I mentioned before, but really her problem is more of a control issue here, and I think this will become apparent to you with her jumping. Okay, first she's traveling all around the room with that. She's having trouble with actually controlling her mass with this. She's going into a fair amount of valgus collapse, especially on the right knee. You can see there where the knee actually passes midline on her on the right side. And again, much more hip adduction in the jumping condition, 20 degrees for hip adduction on the right, 18 on the left. And again, less knee flexion as well. This athlete had strength deficits on the right side that were 18% weaker than the left, but normative values for this proximal hip strength for this young lady should have been about 40% of her body mass. She was actually well below that on both sides as well. So yes, she had some significant strength issues, but she also has what I refer to as more motor control issues as well, which was leading to that valgus collapse. Let me show you one other athlete here. This young lady is 6'5" in height. Let's take a look at her single leg squat. Okay. And now the left side. There you go. Now, again, looking at her data for that. Now, again, the way this data was calculated, I went to peak knee flexion for the motion and then looked at the position of the hip and knee at that instant in time. But again, at peak knee flexion, she was in 26 degrees of adduction of the hip, and 17 on the left. And again, look at the amount of hip flexion, knee flexion that she's going through as well. She had a difference in strength of 30%, with the right side being weaker, 30% deficit. And again, based on normative data, she was well below the norms by almost 40% as well. So significant proximal hip weakness. But let me show you one other thing with her. And this is the force plate that I was mentioning. The last portion of the functional movements, we actually asked them to stand on a force plate, jump as high as they can, land. And I want to show you this as well. So here she is. And you can see just how I have the vectors being displayed in a cone pattern here, but you can see how she's asymmetrical in the way that she's actually carrying her weight upon landing. And then if you watch that, she actually loses her balance going backward as well. So she landed very stiff with minimal hip and knee flexion, yes, but her weight was actually asymmetrical and being carried more on the right side. And again, there's a motor control factor here as well with balance. So one of the things that I'm interested in is looking at the actual control of these lower extremities and coming up with a better way to objectively assess this control. That way, hopefully, we can gain a better idea of how to handle it and also be able to see if our interventions are affected with it as well. So what I've done here is I've placed a tracer at each knee and showing also the center of mass. And you'll see here with the single leg squat from this first athlete that I showed you. And you can begin to see the trace here showing the movement in the frontal plane from this view. And then on the other side, again, remember her affected side was the left. You can see much more of gap in the tracing here. She actually has much more of a looping pattern with that. Now again, her form isn't, again, if the athletes that I've shown you, she's probably had the best actual form from doing a single leg squat. But let's look at the athlete that I showed you that had the poorest form. Again, same markers set up, each knee, center of mass. And you can see a much bigger looping pattern here. And as well on the right. So what are the takeaways from this screen? Strength itself is a factor. It needs to be considered and objectively assessed. I feel very strongly for the use of hand dynamometers with this. They're portable. They've been shown in the literature to be reliable. And then converting that to a percent body weight value, then that allows for comparisons not only between athletes, between teams, by position. And also it allows us to see if some of these intervention programs, some of the strength and conditioning folks are putting into place, to make sure that they are effective. A lot of times they believe that some of the programs they've developed are targeting certain muscles, but then when you go back and really look at the changes in the athletes, those changes just aren't there. It also allows us to look at side-to-side comparison. If you're familiar with the literature on strength assessment in athletes, as little as a 10% side-to-side difference has been shown to be a factor as far as resulting in as a causative factor for injury. We just can't assess that with a true manual test. Our hands aren't that sensitive. If you look at some of the recent data for strength assessment, hip and knee strength, has been shown to be relevant in all sports: football, ice hockey, track and field. If you look at some of the work of Thornburg from Knee Surgery and Sports, also American Journal of Sports Medicine, track and field community, some of the work by Tyler and others, have all shown side-to-side deficits with these athletes as being a factor they feel for their injury. As far as for predicting injury, if you look at some of Crow's work from 2009, working with rugby players with groin injury, one of the earliest articles that came out was by Nadler. He worked with Division I women's basketball as well, and he found that that more than a 10% side-to-side difference in strength of the hip extensors was predicting lower back injuries during the season for those athletes. And then I actually published an article in 2018 with some of the work I've done with the National Ballet, looking at hip strength with the performing arts. So some of that literature is there. But from the standpoint of motor control, that's a little bit trickier for us. From the tasks really that I've shown you today, just briefly, these issues can easily be visualized both in the sagittal and frontal planes. And what I mean by visualize, I mean just that. We actually can watch these athletes or performers perform these tasks, a single leg squat or a single leg jump, and you can see this poor alignment. However, we can't really get objective data from just video, but the Neuraxon system really allows us to objectify what components. Is it true adduction of the hip, and if so, how much? And then the valgus values with the knee through the software is actually more of a dynamic valgus when you look at how the software totals that value, contributing both the sagittal plane flexion along with the rotation, and then finally the frontal plane components. But what's the best way to assess this? As I mentioned earlier, I choose a point in time, and then I look at the alignment at that. I choose the instant of peak knee flexion, and then I look at the alignment of the hip, the knee, and the ankle. But is that really the best way? I don't know. Like I said, it's what I do, and it's what I do right now. But maybe what we might see is tracking of these trajectories might be a better path, and looking at some of that data. Like I said, the MR3 software allows us easily to look at that, but yet we haven't seen that in the literature just yet. Other things is the timing of the screen. As I mentioned earlier, due to the university's request, we did not do the screen until mid-September. And then they began full-scale practice, scrimmages, and games beginning in October. The problem with that is it really did not give their strength and conditioning folks adequate time to address the deficits that they found. Now, once we gathered the data from the screens and we put together our report, I met with the strength and conditioning staff, and they quite honestly were surprised at the amount of data that we were able to generate. And then they began to realize that by using this data, they could better tailor their preseason conditioning program for each athlete as opposed to the team as a whole. Sort of using a metaphor of a one-size-fits-all T-shirt. It really doesn't. And some of these athletes had actual strength issues. Others had, honestly, their strength wasn't the biggest thing, as more as the control. But they needed a longer period of time to address the deficits. So since then, we've agreed to move the screen to having it performed immediately after the season, which would then fall somewhere late March, early April. And then they can then take that data, develop programs through the summer, and then they want us now to repeat the screen in late August, essentially doing twofold. One, the athletes know that this extra screen is coming, so they'll be a bit more diligent through the summer with their workouts. And two, that would still give them time to address any other deficits coming. And that second screen in late August would also allow us to capture the incoming freshmen. And then other issues as far as the results. The strength deficits, quite honestly, the strength and conditioning folks do a great job of developing programs. And again, the input from the screens allows them to tailor them to meet the individual athlete's needs. But the motor control part is a bit different. It's more than it takes more than strengthening to resolve these deficits. And you may need to educate their strength and conditioning staff with different types of techniques and activities to address these deficits, because that's not really the wheelhouse, if you will, for the strength and conditioning staff. Hewitt was the first to describe, the jump drills activities in volleyball players in 2005. And then, of course, there was different work done with the Santa Clara Project soccer, women's soccer later. But as far as coming up with ideas of techniques and all that they could use to address these motor control issues, they may need some additional help with that. And quite honestly, the athletes will probably benefit from having testing done after several weeks of these drills to make sure that they're on the right course as far as resolving them. Well, I've covered quite a bit of ground, and